allow me to speak about, but now I say no. I'm not thanking you because this is a very tricky situation you are putting me. I have everybody against me. You have heard all the people before me, and now I should say that no, you don't need PSMA or MRI guided treatment. And this is something very embarrassing so early in the morning. So these are a few disclosures of mine. Let's go back to the definition. What is an algorithm? It is a set of rules that precisely defines a sequence of operation. What is the best set of rules we have as urologists and radiation oncologists nowadays? Guidelines, EAU and ESTRO guidelines. And what they say, you need MRI before biopsy, whatever you look at them, strong strength rating about that. So I go home, see you next year. But when you look more in detail about staging, and this is what we are discussing today, staging, so how to get information on organizing the management of your patient, where the strength rating goes down to weak. So all the panel at the guidelines of EAU and ESTRO had to recognize that we don't have so strong elements, so strong evidence to say that using MRI for staging is, well, so strong evidence. Of course, I'm not talking about these kind of patients. You don't need an MRI. Probably my finger would be good enough to understand that this is an extraprostatic disease with an infiltration of the seminal vesicle. I'm talking about these cases that we see every day in our clinical practice. Patients in which, of course, we see a big mass somewhere in the left lobe of this gland, but do we trust our MRI reader about extraprostatic disease, infiltration of seminal vesicles, or whatever information we need to build the management strategy for these gentlemen? Not that sure. And indeed, the guidelines tell us why this is only a weak strength rating about MRI as a staging procedure, because traditionally, as it said here, we have qualitative signs that should be used to check, to guess if we have extraprostatic disease, infiltration of seminal vesicle, and in this subjective space, the experience of the reader remains of paramount importance, and intra-reader agreement is, at best, moderate. So this is what we have to base our management strategy in our patients, something which is only, at best, moderate. And if you ask yourself, and this is probably a question we have already discussed early this morning, but this is the urology world that tell us this, how can MRI predict for some very important pathological features at radical prostatectomy? And this is a very recent work made by and presented at one of the recent AUA meeting. They check on 100 patients how MRI previously to radical prostatectomy can guess about important features at the pathology. Well, you can see that the sensitivity is quite suboptimal. And this is a contemporary series of radical prostatectomy, a good center where good MRI readers were reading this MRI. How to trust all this? In the radiotherapy space, we have heard already about this holy grail of radiotherapy, the idea of boosting intraprostatic lesions by external beam radiotherapy or brachytherapy. Why not? And you know, we have already been discussing this, that the FLAME trial is a fantastic proof of concept. Yes, we can do this with external beam radiotherapy, and yes, this translates into very good results with, you know, local failure, which are halved, with regional and distal metastasis-free survival, which is also interesting. And this has fueled some nice review articles, which has been published a few weeks ago in the European Urology Oncology Review. They took 17 studies, all dealing with this new concept of intraprostatic boost with radiation oncology. And if you look into details, because as usual, devils is in details, you will find this sort of sentences. Criteria for intraprostatic lesion eligibility for a dose boost were not clarified in many studies. It is also unclear which types of intraprostatic lesions should be eligible for dose escalation. At present, studiously frequently used diagnostic multiparametric MRI, but the procedure is far from being optimized and standardized. It's unclear whether all MRI-identified intraprostatic lesions were delineated and underwent a dose boost. And finally, the contouring protocol in these studies are unavailable and guidelines are not still defined. So the whole picture we have in this space is very, very disappointing to my side. Using multiparametric MRI to define intraprostatic lesion, look at that. And why is that? Because in my opinion, all these studies are lacking something we have been discussing today also, is pathology confirmation. And we know that as soon as you compare MRI with pathology, you have these kind of results. Multiparametric MRI detect only a few pathology lesions, and sensitivity is very low. We may discuss, as it has been, are all missing lesions clinically significant for your patients? I don't know, only longer follow-up will tell us, but this is where we are in 2022. PSMA PET. PSMA PET indeed added a lot to our cancer armamentarium. It raises many questions, not sure it gives us many answers. Of course, if I again go back to the guidelines, there is a clear indication that PSMA PET may be used, especially in two clinical situations. The most important one is after radical prostatectomy. When you see a PSA rising, you may want to know where this PSA is produced in order to organize your management algorithm. But this PSMA is only suggested for sufficiently high PSA. Because as you can see here, if you look at PSMA positivity for very low PSA, rising PSA, well, this is not good enough, 33%. But even for PSA level of 0.2 to 0.49, the PSA positivity is only 45%. And sorry to say, if you ask me, for a patient having a PSA rising after radical prostatectomy, 0.4 nanogram milliliter, does he have some positivity if you do a PSMA? I have a very good way, which is more than 50% correct, to tell you if this is a disease somewhere or not. Studies like this, like the Empire 1, told us that probably, as compared to conventional staging, PSMA may add something in terms of best defining the lesion, and so better management of our patient. And indeed, the Empire 1 studies showed that as soon as you integrate PSMA, you may also have, this may translate in some event-free survival advantage to your population of patients. Why is that? Because you may better tailor your treatment. But again, they will see it in details. If you look to the multivariable analysis in this study, there are other, much more simple prognosticators that have exactly the same, even more impact than the study group in this respect, which are PSA, extracapsular extension, and the radiotherapy field we use. So PSMA probably in this respect does not better than all those very well-known prognosticators. And studies like this one were telling us that PSMA is also important after radical prostatectomy. These are studies showing that the mapping of N+ disease is not the one that we as radiation oncologists would contour in our daily practice. So if you compare where the disease is found by PSMA, the blue spot here, well, this is far beyond my red contours. And so this is a warning. If you use a PSMA, you should adapt your contour. But again, if you look into the details of the paper, you will find out that the mean PSA when PSMA was done was 2.4 nanogram milliliter. Who cares about information about PSMA localization when you have a PSA of 2.4? I would need this information when PSA is 0.6, 0.7, 0.4, and we don't still have it with PSMA. Of course, I'm not saying that PSMA is not a good tool. It has a very good specificity in the primary setting, in the salvage setting that may be used. What I'm saying here is that probably we need to change strategy and to identify patients that may need PSMA in their journey. I'm not sure that 100% of our patients will need PSMA, so this is the way to go, identifying best candidates for prostate-specific membrane PSMA. There is a nomogram which is proposed in which you may guess which patient may be upstaging using PSMA as compared to the general population. I will quickly conclude, just remind you, it has already been done, but this is an important piece of information, that there are pitfalls as soon as you use PSMA. This has been mapped in a very clever fashion. When you see ribs or spine or pelvis lesion, you may ask yourself, is this real disease or something else? You don't want to be like this radiotherapist who enthusiastically tweeted 1 year ago, I got my first PSMA in a patient, I identified a solitary rib metastasis because soon after Michael Hoffman from Melbourne told him, slow down my friend, we have too many false positive PSMA PET reports when talking about ribs. And so what you don't want is to risk to deny a life-saving treatment on the basis of a so-called positive PSMA PET. My conclusion is that you have to be careful. Reality is not always as you imagine it. You have to have different perspective to find out that probably you made a mistake at first sight. Thank you for your attention.